Good afternoon. Welcome to the City Club of Cleveland. I'm Jay Gershon, president of Northeast Ohio Medical University and a proud City Club member. It's my privilege today to introduce our event, a panel conversation about the move from volume to value-based healthcare. The United States spends far more on healthcare than any other industrialized nation. In 2012, we spent an average of $8,915 per person on healthcare, reaching a total of $2.8 trillion. Those figures are more than 2.5 times more than most developed nations in the world, including high-income European countries like France, Sweden, and the United Kingdom. On a more global scale, it means our healthcare costs now represent 17.6% of the gross domestic product. So how did we get here? That is a subject of much debate. However, a major component of the Affordable Care Act is to change the way hospitals are paid in an attempt to begin to lower healthcare costs and improve quality and outcomes for patients. For decades, hospitals and physicians were paid a fee for their time and/or services provided, independent of their success. It is commonly referred to as the fee-for-service model. The more tests and procedures ordered, the more payment was received, driving up healthcare costs. With the advent of the Affordable Care Act, we are transitioning from a volume-based model to a value-based model focused on costs and patient outcomes, quicker recoveries, fewer hospital readmissions, lower infection rates, and fewer medical errors. Many have questioned the feasibility of this transition and what it means for both patients and healthcare providers. The panel we have assembled today can help us come to a deeper understanding of this issue. Here to guide today's discussion is WCPN health reporter and producer Sarah Jane Tribble, a self-described recovering print-only journalist. Ms. Tribble spent more than a decade reporting on healthcare, banking, Silicon Valley technology, and energy for multiple former Knight Ridder newspapers. She moved to Cleveland to become part of the Plain Dealer's medical reporting team in 2007 and joined the staff of WCPN IdeaStream in 2013. Please welcome Sarah Jane Tribble.
Well, thank you very much. As we just heard, the American healthcare system is irrational. It's been a lot of fun to cover as a reporter over the last more than a decade. But the thing about it is, when you talk about the fee-for-service and the transition to value-based care, the people who are really caught in the middle are two groups. It's the doctors and hospitals and the patients. And so that's why we're here today. We want to figure out, and we're all part of this larger national conversation about how to get value and not just get bills that we don't know what we're expecting. Too often we get a bill from the hospital and you don't know why you're paying that price. Too often you call to see if you can get a procedure and check the price beforehand to see if your high deductible health plan will cover it or if you'll have to pay it out of pocket. And we don't have answers. And the doctors who are caught in the middle are here to talk to us today, so it should be a really great conversation. We're going to pick on Dr. Alan Hirsh here in the middle because he was a last-minute add-in. You may see in your programs that Dr. Michael Anderson was supposed to be here from UH. He could not be here, so Dr. Alan Hirsh is filling in. He is the CMO of Ahuja Medical Center. We have Dr. Alfred Connors, who is the CMO of MetroHealth, our taxpayer-funded hospital here in town. We have Dr. Giesele Greene. She's the Chief Medical Officer of Sisters of Charity, which you may know from the St. Vincent Hospital here near downtown. And we have Dr. David Longworth. He is the chairman of medicine of the Medicine Institute at the Cleveland Clinic. And we were joking about his title earlier because it's so easy to say chief medical officer, but he's the chairman of the Medicine Institute at the Cleveland Clinic. So this illustrious panel, this should be a great conversation. I'm going to start off with a fairly easy question, and that is to ask each of you to go down the line and give us your definition of value-based care.
Want me to start?
Sure, that'd be great.
Well, value-based care is something I think that's simple to understand. It's getting good quality care and good outcomes for a reasonable or low price. And so if you want to increase the value of care, you increase your quality, you improve the patient outcomes, or you decrease the cost. And the current model is to set up incentives and penalties to push us in that direction.
Right. We'll get to those incentives and penalties in a minute. What's your definition, Dr.
Well,
Greene?
I think it kind of depends on who you ask. If you ask the consumer, the patient, of which we all have been or will be at some point in our life, you want the value-based healthcare system to guide you in how to stay well and to treat you courteously, compassionately, efficiently, effectively, and with the best medical care possible if you become ill. If you're a payer of health care, you want to be able to cover as many people as possible, say if you're a government payer or a commercial payer, for the least amount of expenditure, which means then it's to your advantage to help keep healthy people well, who are the majority of your clients, and to focus in on the 5% of the population that is driving 50% of the healthcare costs. And that is where the value comes in. If you can focus in and effectively manage that 5% that's driving the largest amount of expenditure, then you can get better value overall for the healthcare system. Now, if you're in the provider community like we are, with hospital systems and physicians, you're kind of caught between the consumerism of trying to deliver the best care possible and the payer community, where we're trying to be as judicious as possible with the expense of dollars. And you have to respond to both the government mandates as well as to the commercial payer contracting related to being able to effectively manage that 5% of the population. And so value-based healthcare from the provider standpoint involves, just as Dr. Connors said, being able to deliver that value at the lowest cost. And also, for us, it requires a retooling of our clinical operations. It has required investment in technology, and it has also required that we pay good attention to the social determinants of health as we manage people across populations.
What about you, Dr.
Boy,
Hirsh?
that was impressive.
Yeah, I mean,
That was comprehensive. What I would like to add, though, is I think we have to get a sense of what the country is going to get for their healthcare dollar. And I think that's where population health management, really, which is a new buzzword in healthcare, is going to start to come in. And I think managing the 5%, but also the larger groups of patients, and really in the preventative world, I think we can really start to deliver value in the population sense. And I think that's something that we're going to start to see more and more of. We're already starting to see more of it.
okay. Dr. Longworth?
Well, I think my fellow panelists have really covered the issue well. I like to think about the value proposition as an algebraic equation. The numerator is quality or outcomes. The denominator is cost. And so, hearkening back to high school algebra, you can improve value by improving quality or outcomes and maintaining cost. You can improve value by maintaining quality and outcomes and lowering cost, or aspirationally. And I think the journey all of us are on is to drive improved quality and outcomes, and at the same time to make care more affordable, more appropriate for individual patients and for the population of patients in this country. Up until very, very recently, healthcare has been about a business of disease management. It's been reactive, but inherent in the concept of population management and value-based care is being in the business of wellness and prevention, building a system that will stem the tide of obesity, diabetes, high blood pressure in this country.
I really like that mathematical formula, that analysis, the quality and the outcomes over cost, because then you can kind of say, okay, quality and outcomes, that's going to be, how we treat wellness and prevention and how we're going to make sure our patients are healthy. And then the cost, that really gets down to, the other side of the coin. We're going to have to put in electronic medical records so we can manage that population, but that costs money. We're going to have to make sure we have the best technology available to help manage that population. So that's a really nice framework, I think. One of the things about the Affordable Care Act is it does have those sticks and carrots in it to try to drive the healthcare system overall. And so it's changing the way major federal dollars are coming to the hospitals, right? So Medicaid has all these kind of pilot programs within it, and other initiatives. Medicare as well. Medicare has a couple of big initiatives, one that's hit very recently. Let's start by talking about the initiative for the hospitals on the idea of quality outcomes and measuring those. I know Medicare is measuring a host. I don't remember the total number. Maybe one of you can help me with that. 18 different outcomes, including patient experience, to say, we're going to reimburse you extra if you do really well on these outcomes. We're going to reimburse you extra for every patient if you do really well on these outcomes. And I know that all the hospitals here have been working on it, and all of you have been very involved. I was going to ask Dr. Longworth to kind of start out with the answer on that one, to say, because I know the Cleveland Clinic has honed in on patient experience of the many things you can measure. And you started working on that even before the ACA. So if you could talk about how that plays into the Medicare reimbursement.
Certainly. So, you know, Sarah, this is really the most transformative time in healthcare that I have lived through, and I would argue that we've lived through in the past 50 years. It's really changed the way we think about what we need to do to deliver care. We've got to transform our care delivery model. We've got to drill down hard on improving quality outcomes and making care more affordable. You know, if you can't measure it, you can't monitor it, and you can't improve it. And so as we think about driving to the quality measures in the Affordable Care Act, there were 33 last year. They've just been revised in the last week or so.
Wow.
If you can't measure and monitor them, it's going to be tough to know how you do. And more importantly, you've got to get the caregivers in the game. You've got to share that data. And we at the clinic have been on a journey of transparency, sharing data, how we do well, how we don't do so well, and where our opportunities are. And so this emphasis on outcomes and quality really has had profound implications for our ability to measure, monitor, report, and then to redesign our care delivery model to drive towards value.
One of my first trips to the Cleveland Clinic, I went and saw one of the dashboards you guys keep for measuring quality measures, and then also you print a publication for each institute.
We do.
And then the doctors have to kind of be out there with how they're doing, right?
We absolutely do.
Does that cause any internal riff among the doctors, being competitive like that internally?
Well, doctors like to get an A. They like to get an A plus. But you know something? If we don't know how we're doing, we can't get better. And so people have really signed on around this. And no, I think we've gotten by that. People have embraced it.
And I know at Ahuja, as it was being built, there was a lot of talk about patient experience, a lot of talk about making sure the new facility there was built around what the patient would enjoy. So was that Medicare reimbursement a factor in that?
Well, I think not really. I think we really thought about what the patient's experience is going to be like. I think we use that as a driver from everything from the design of the building to the way we oriented our staff to the way we approach patients every day. And then, do you get the scores to match the output that you're putting there? And I think anybody on this panel can attest that it's very difficult to do well on patient experience scoring. It's a zero-sum game, and 50% of the hospitals in the country will do well, and 50% won't. And it's very tough for even the best institutions to get that always score that you have to get from a healthcare from a patient to do well on the survey. So I think one of the great benefits for every patient in the city has been that every single hospital, and certainly every single hospital in the country, is striving to get the always score. And so people are tripping over themselves, frankly, to give great service. I think you walk into any hospital in the country today, your experience is going to be a lot different than it was 2 years ago, because people understand how important customer service is. We're all studying Hyatt Regency, we're studying Ritz-Carlton, we're learning about how to give that kind of sort of hands-on touch to patients so they really feel comfortable and they feel safe. And that's a big part of what we've done at Ahuja, and I think we're all doing the same thing.
So I'll look at the hospitality industry
right.
as an example. Now, you guys, we've talked about patient experience. Dr. Greene, Dr. Connors, are there any of those other measures, 33, that really have been something you guys have focused on? I'm sure you're looking at all of them, but something that's really come to the forefront.
Well, you know, we've been having to look at infection rates in hospitals, right. And we've been having to look at conditions that happen in the hospital that patients don't come in with, hospital errors. And I think that there has been a focus put on that with the Affordable Care Act, as well as with readmissions, which is someone gets discharged today, are they coming back within 30 days for the same ailment? And if so, why? So many of the, there were 3 pay-for-performance programs in the Affordable Care Act. One was readmission reduction, one was value-based purchasing, which was kind of a reward penalty program, where if you did well, you got rewarded. If you did poorly, someone else took part of your reimbursement in terms of the hospital pool. And then there's the healthcare associated conditions portion of the pay-for-performance program, which looks at those events that should not happen, errors, hospital errors, injuries, as well as infections. And so I think there's been a great deal of re-engineering of clinical programs to make sure that we're not making those medical errors, to make sure that we're addressing the items that would cause individuals to come back to the hospital. You can have great medical care, and Dr. Hirsh can see a patient and write the prescriptions and prescribe the diet, and they can go home, and if there's nothing in the refrigerator and they have heart failure and they've got $10, they'll call and order a pizza. Okay?
Right.
That blows your whole sodium load for the week, and you're ending up right back in the hospital. But you can't be home and be hungry. So, I mean, these are very real issues that you have to address. It's got nothing to do with the exact health care you got in the hospital, but we've had to make that transition from hospital to what the next destination for care is.
I'll never forget going out for an assignment for the plain dealer, and it was university hospitals, but I think it could have been a number of the hospitals in town, and they were trying, a year before the readmission penalty came out. And this is a penalty, a percentage off of every Medicare dollar you get, not off the patient that you treated, but off of every Medicare dollar you get. So this is millions of dollars for the hospitals if they don't get this readmission rate down. So I went out with a home health worker that was employed, I think, by university hospitals at the time. And this woman that we were visiting, the patient, had been released that day or the day before from the hospital for heart surgery. She had high blood pressure. She had a host of other issues and ailments. And her teenage grandchild was there watching over her because and they didn't have anything in the house but canned food to eat. And she had high blood pressure, and she'd just been released on heart surgery. And all they had in the house was canned food. And the home health nurse comes in and says, no, you can't eat any of this, right? I mean, this is the real problem we're dealing with. So Dr. Connors, when you talk about readmissions and that involved with the folks that are going home, just as Dr. Greene mentioned, what are the biggest challenges there? How are you guys tackling that?
Well, we're really concerned about that transition from being in the hospital to being in the outpatient setting. Because often when people come in the hospital, everything changes. We change their medications. They're recovering from an acute illness. Some medications that they would normally take, they can't take. They're taking additional medicines. So it's easy for people to be confused about the medicines they're on and make mistakes. And so we try to educate them before we go. We've actually hired, we call them transitional care coordinators, people who call patients up, make sure they know what their medicines are that they're taking, that their prescriptions have been filled. And importantly, know what to do if things go poorly. So if they're having problems or they're developing symptoms, when should they call the doctor? And the answer is generally the earlier the better, because we can often get people in, deal with the problem when it's small, and not have them wait until they're really sick, come to the emergency room and need to be admitted. And finally, make sure they have an appointment with their primary care physician. Know when that is. Their physician knows it's coming. Their physician knows what happened when they're in the hospital. So there's all that good communication, and the patient shows up and makes that appointment. So just getting those 3 things in place helps. And you know, at Metro and in some of the hospitals in the city, we deal with populations who don't have all the resources at home that you might have you might expect to have. They might not have family members to help them if they're sick. They might not have a home to go to. They might be living in a shelter or a hotel or whatever, so that those people are actually more fragile, more likely to have trouble. There aren't people to go out and advocate for them, and we try to provide extra support for those people. So that there are a lot of things that go into getting this readmission rate down. And it's not just about medicine. It's really about helping people cope with the healthcare system. It's confusing, and it requires a lot of education, a lot of communication.
I want to come back to the idea of,
I just want to make a point that all the things we're talking about cost hospitals money. And it's an interesting, nice thing about the Affordable Care Act is it's forcing the providers of healthcare to invest in quality. So we're now not so worried about the piece that we're providing for people, but in fact we're investing in, it happens to be that we're going to be measured on readmissions, but it's an investment in quality. So patients are actually getting better care because we're going to be, we're being held accountable for it.
But are the measures fair? That's the question I was going to ask. So if you're investing in quality, and if the Affordable Care Act is saying let's look at this measure and the outcome on it, is it fair to judge a hospital's outcomes the same across the board if they're serving different patient populations? And I'll ask Dr. Connors to answer that first.
Well, it's a fair question. And the question you're asking is when people look at the statistics, they see that hospitals that are caring for, like public hospitals, safety net hospitals that are caring for populations that may be financially disadvantaged or not have the resources to at their fingertips to care for themselves, they tend to do less well and be more likely to be readmitted. They may have trouble filling prescriptions. They may have trouble getting to appointments. And any slip like that can lead to somebody having a bad outcome, getting sick, needing to come into the hospital. Now, so that some people have advocated for taking that into account and adjusting for it when you're setting these goals. They decided not to do that. I kind of like that. I don't want people to think that that if you're poor, we're going to accept less optimal care.
Right.
We should be striving, everybody should get the same level of care, and we should be doing what we need to overcome those obstacles. But the obstacles are there, and we have to figure out how to do it, and we do struggle with it. So we've made progress in reducing our readmission rates, in some places really quite a bit of progress, but we do face difficulties with certain patient populations that are difficult to overcome.
Okay, Dr. Longworth is eager to talk down there.
So, you asked the question, is the Affordable Care Act fair?
That's a broad question.
I think of it in slightly different terms. The Affordable Care Act has taken a pounding. It's been highly controversial. But I don't think without the Affordable Care Act, we'd be having the serious conversation we're having in this country today around quality and affordability. In that domain, for me, it's been a huge success because it's forced us as a country and an industry finally to think about these issues. The second point I'll make, and then I'll... The second point I'll make is the metrics. Are the metrics fair? Are they nuanced? I personally think that we are in the infancy of quality and outcomes science. Yes. And I think 5 to 10 years from now, what is defined as great quality and great outcomes will be much more sophisticated than the very rudimentary, from my perspective, low bar standards that we've set around payments.
Now, there are some things that are codified in the medical literature as just things that need to be done because it's the best way to deliver care.
Right.
And we've seen since 2003 when those first started to be measured by CMS, the numbers jump from 55% of the time doing the right thing in the healthcare setting to well over 95% on those core measures. But what we still are struggling with in terms of delivering care, particularly to vulnerable populations, are the social determinants of care. And I think one of the things that we've done at Sisters of Charity Health System is to not only try to leverage our hospital resources with navigators and others that are helping people with discharge planning and providing vans for transportation to get people to and from appointments that can't afford it. But we've got our Sisters of Charity Foundation, which is part of our system, has focused on working with the model Housing First. And we've been very successful since 2008 in helping to reduce chronic homelessness, which is a risk factor for readmission, a risk factor for emergency department admits, by helping to fund and put into place over 600 units of housing here in Cuyahoga County with Cuyahoga County Housing First. We've also initiated efforts to try to impact the lack of fresh fruits and vegetables in the central neighborhood. St. Vincent Charity Medical Center has been there for 150 years, and the Sisters of Charity Health System is right there in central, right with our hospital. And so trying to make an impact in the community, I think, is extremely important so that we can systemize some of these changes. And the City of Cleveland is trying to do some of that with Healthy Cleveland, and which we're all participating in as well. So I think it's a little bit larger than just what we can do as the hospitals, I think to a certain extent we're in a transformative era for the country, and looking and now recognizing that there are things that impact health that really reach farther than just the relationship between the patient and the physician.
Right.
Dr.
Connors first, and then Dr. Longworth.
I wanted to make a point that the point was made, and it's correct, that when you go after and try to improve quality, it costs money. And there are initiatives, we have to put people in place to do this, we have to put resources into this. But most of the time, good quality care costs less than poor quality care. If you prevent complications, you don't have to pay for the consequences of those complications. If you prevent someone from getting sick and needing to be admitted, the cost of healthcare actually goes down because you've avoided an expensive hospital stay that wasn't good for the patient because if it was preventable, there's something we could have done to keep it from happening, and that cost goes away. And the people, you do it by making people healthier. So they're feeling better, they're enjoying their lives more, and healthcare costs go down because we have fewer infections, we make fewer errors with medications. People are less likely to fall in hospitals, less likely to get bed sores, less likely to go to nursing homes. If we put all these things in place, and all of these initiatives are pushing us to improve our quality in a way that's going to absolutely be beneficial for patients and will drive down the cost of healthcare. So I'm with you on the Affordable Care Act. I think it is exciting, and I think it's pushing us to a healthcare system that we've needed in this country for a long time. It's going to be good for all of us.
So, Alan, Giesele, I just want to build on the points that you've made, because as I've lived through this and thought about how we deliver health care in this country, I've seen the world through the lens of the doctor. Mm-hmm. We have delivered health care in bricks and mortar, reactively. Patients come to us. It's been all about sickness and not about wellness. And I think our challenge as we begin to think about transforming the care delivery model is to leverage other resources that we haven't tapped to drive wellness, to help people make great decisions about their chronic diseases. What are those? Churches, schools, other community organizations. We've got to be about the business of well care in our society, in addition to being about the business of health care.
Absolutely.
Okay. And part of what's happening too, I think, as we're living through this era is that the healthcare workers, and I think I'm speaking for all of our hospitals and the system at large, we're undergoing a cultural transformation where there's becoming a better appreciation of what it means for customer satisfaction, what it means to disclose errors, because you want to know where the errors are so that you can improve. So this whole culture of quality improvement and patient-centeredness, putting the patient first, is something that I think is going to be on an increasing trend and is going to also help to drive the quality.
We're running out of time, but I want to ask and end with Dr. Hirsh and ask you, this could go for everybody, food for thought. What is it when it comes to these value-based purchasing that we started off talking about, when it comes to the value of healthcare, what are you most excited about for the patient in the next 5 years? What change are you most excited about?
I think, as David said, it's all about wellness. I think that's where we're heading in this country. It's where we've been way behind the rest of our developed Western colleagues. We have to do better about keeping people healthier so we can not have to spend so much money taking care of them when they're sick. And I think that's really where I'm excited, because I think we're already starting to see it. We're seeing decreased rates of obesity starting already with the very youngest children. The message is starting to get across, and I think that's really what's exciting to me.
Yeah.
What excites me is that we're removing some of the things that people are most scared about in healthcare. People it used to be you come in the hospital, you're afraid of getting an infection, having people make a mistake with the drug, get the wrong medication. And I mean, we couldn't say those things didn't happen, because they did happen. And there were national studies that showed they happen way too frequently. Over the last 5 years, we've all been working on making it hard to get an infection in the hospital, making it hard to have an injury in the hospital, keeping people safe, automating all of our processes so it's much harder for a patient to get someone else's medication or get the wrong medication, so that people can come in, get their care, hopefully less frequently because they're healthier, but when they're there, we're doing a better job of keeping them safe, and that excites me. I think we're doing a better job across the board.
And I think on that note we'll have to end, but open it up to the audience. I'll let Dan come over and guide us.
Hello, I'm Dan Moulthrop, Chief Executive here at the City Club, and thank you all for joining us for our Friday Forum panel discussion on healthcare delivery from volume to value, featuring Dr. Alfred Connors, Chief Medical Officer at MetroHealth System, Dr. Giesele Robinson Greene, Chief Medical Officer at Sisters of Charity Health System, Dr. Alan Hirsh, Chief Medical Officer at the University Hospital's Ahuja Medical Center, and Dr. David Longworth, Chairman of the Medicine Institute at the Cleveland Clinic. And thank you very much to Sarah Jane Tribble for her expert moderation. We're going to transition to the audience Q&A in a second. We remind you to prepare your questions now, ask that they be, in fact, questions and be brief and to the point, but we encourage everyone to participate. And we welcome all of you here and those joining us via 90.3 WCPN, WVIZ PBS, 104.9 WCLV Idea Stream, which is our primary media partner, or one of the many radio stations across the region and country that carry City Club programs. You can also, I should say, tweet your questions if you're listening on the air to us at the City Club. Television broadcasts of the City Club are made possible by Cleveland State University and PNC. Our live webcast is supported by the University of Akron. Next Friday, November 14th, the City Club is pleased to welcome Richie Paparinen from Cleveland State University's Maxine Goodman Levin College of Urban Affairs and the Center for Population Dynamics. For more information about that program or any of our upcoming programs, please visit us online at cityclub.org. We welcome guests at tables hosted today by the Cleveland Clinic, Medical Mutual, MetroHealth System, Sisters of Charity Health System, St. Andrew's Episcopal Church, and the Center for Health Affairs. Thank you very much for your support. Today's program is sponsored by the Sisters of Charity Health System. We thank you very much for your support. Today's program is also the Medical Mutual Endowed Forum on Healthcare, made possible by a generous gift to our endowment for Medical Mutual. We thank you very much for your support. And now it's time for the traditional City Club Q&A. We welcome questions from everyone, including guests. Holding our microphones today are our Director of Programming, Stephanie Jansky, and our Content Associate, Teddy Eisenberg. Do we have our first question, please?
Good afternoon. I want to just thank you for being here. This was a wonderful forum. In the schools, with the obsession with testing, there's been a de-emphasis on health classes. And so often, if young people have health classes, they can kind of guide their parents or grandparents in doing the correct thing, especially when there's opportunities for fruits and vegetables in the neighborhood. So my question is, are you partnering, are any of you partnering with any school districts or creating any opportunities for patients or especially young people to learn healthy eating habits?
Let's give that one to Dr. Connors first, and then maybe Dr. Greene. Is that?
We've been working with the St. Luke's Foundation. They have a program called Healthy Eating, Active Living, which is really a community-based program to increase exercise, increase the availability of fresh fruits and vegetables in the community, and also gardens in the community. That's been very effective, and we've been very proud of.
We have several initiatives at Sisters of Charity Health System, primarily through our Sisters of Charity Foundation of Cleveland, as well as through our Building Healthy Communities. The Building Healthy Communities initiative for our Sisters of Charity Health System has actually taken neighborhood kids and provided neighborhood gardens, which are funded by the system. And we also provide an outlet for those individuals, those youngsters who are harvesting and tending to those crops, to come and sell their wares on hospital and Sisters of Charity Health System owned property on a regular basis. We've been doing that for a number of years. Through the Sisters of Charity Foundation of Cleveland, we have the Healthy Eating, Active Living. We also have what we call our Cleveland Central Promise Neighborhood Initiative, which is, has the Cleveland Municipal School District as a direct partner. We are working aggressively with them on redesign of the schools that are municipal schools within the central neighborhood. We also have partnered with the community in terms of training individuals in the community to work under the auspices of the Promise neighborhood. And many of these initiatives do involve the provision of fresh fruits and vegetables, as well as opening other businesses that promote fresh fruits and vegetables within the central neighborhood.
And the only reason I mentioned MetroHealth first is because they're actually opening clinics at some of the schools grade schools here in Cleveland, and they have a doctor there once a week. I don't know, how many schools have you opened in so far?
We've opened in 2. We're planning to have 20 open by I think by the end of next year. Is that?
Yeah.
Yes.
Part of a broader national effort by other organizations.
And we're working with other health systems as well. We're hoping we can get these programs into every school in the Cleveland area.
Sure.
20 years ago, when I lost my health insurance, I was fortunate to be a veteran. I started using the VA system, and then when I got conventional health insurance again, I started dabbling in your systems, but found that the VA was the best place for me. It already had value-oriented service. It already had wellness-based service. And I'm wondering two things. One, what can you learn from the VA? And two, why isn't the VA on your panel? They're a big system here in Cleveland.
That's a great question. I don't know why the VA is not on the panel, but I will let you guys answer. What are you learning from the VA, if anything?
Well, one thing for sure we've learned from the VA is electronic medical records. They were way, way, way ahead of the curve in terms of an integrated electronic record that is really second to none. Why we all don't buy it from them, I don't know, but I guess that's the free market. But they really have taught us a lot about that, and that's been a great thing we've learned.
The other thing is that they really are experts at managing a population, right?
Yes.
It's a large population, and both dealing with, as you've pointed out, not just acute illness, but also keeping people well, dealing with, and I think that that's something that the healthcare systems really hadn't done, because there were we were rewarded for taking care of people when they were sick, or when they came into the hospital, or when they came to the emergency room, and there were no incentives for doing that. But the VA, I think, had a different structure and had those incentives, and were well ahead of us in doing that. I think those incentives are changing. That's part of what the Affordable Care Act is going to do, and it should. We're already thinking more about how to keep people healthy, talking more about it, and doing more about it. So I think that hopefully the differences between the systems will get smaller.
I want to amplify the point of the electronic health record. You can walk into VAs across the country and your record can be accessed. That is really, really huge. If we had a single electronic health record in this country where if you walked into the hospital in LA or in Boston or in Cleveland and we could find you, I think we could take a lot of waste out of the system.
Yes, good.
Obama's post-election comments, he referenced the Affordable Care Act, and he said it's not going to be repealed, but he said, you know, it was passed in an adversarial environment. If I wrote it today, it would be different. We've learned a lot through implementation. There's a lot that can change. And he admittedly said, okay, let's open it up to see how we can fix it and make it better. So my question is, as a panel of healthcare providers, if you had the opportunity, in which hopefully we will, to change, influence, advocate, to change the parts of the Affordable Care Act that aren't working, what would you want to change? And where would your focus be to say, this aspect isn't working, what can we do better? How can we advocate for that?
Who wants to take that one first?
Well,
That's a good question.
Dr. Greene?
Go ahead, John.
Well, first of all, I think we need to be reminded of the things that are working in the Affordable Care Act. And I think we need to make sure that those are preserved in whatever political climate that we may find ourselves in going forward. You know, preventive care is covered. There's 100 million people that have accessed preventive care services. At least 30 million Medicare patients that weren't getting those, and 70 million commercial patients, because you don't have to pay a copay anymore for those preventive health services. Children that can stay on their parents' plans up to the age of 26. I know that helped me a lot as you know, the mother of 6 kids, you know, to be able to not have to worry about what's going to happen with the kids once they age out from college. So there have been many things that have happened, pre-existing conditions. You can't be denied insurance for pre-existing conditions. I think all of those are things that we do need to keep and we need to embrace. I personally would like to see, and I know the Supreme Court had a role in this, but I think the expansion of access was very critical to the overall success of the Affordable Care Act. And the fact that we have half of the states that have expanded access and another half that have not, I think is really a travesty. If someone said to you, I heard Marcia Fudge say this, my congresswoman, if someone said to you that they would pay your mortgage for 3 years in a row, wouldn't you take that 3-year payment and figure out how you would pay it in the 4th year? Especially if they're going to pay 90% of it in the 4th year and going forward. So it doesn't really make good sense not to have expanded it for the level of people that all of us are seeing. We treat a number of uninsured still, although we have been assisted by the Affordable Care Act. The one thing I would do differently is not so much with the Affordable Care Act, but on the opposite side where access was expanded, there were a lot of takeaway programs. So from the standpoint of a hospital and reimbursement and working with razor-thin edges here, the disproportionate share hospital payments are going to be cut. There are the hospital care assistance programs are being cut. So when you look at what the upside was from expanding the access, the downside kind of took it away and you're still behind the 8 ball. So I would provide some balance so that the hospitals don't get cut at the same time they're getting reimbursed, as we're trying to go through this entire transformative process to on the road to better quality.
And speaking of the different things you could change about the Affordable Care Act as this discussion progresses in politics, the disproportionate share funding, actually, they didn't cut it as soon as they expected to. They've extended that deadline, correct?
That's my understanding.
So perhaps that will hang on, right?
Perhaps.
And that's extra. And for those
I don't know. we have a new Congress, so I don't know.
Those in the audience that don't know, that's extra funding to hospitals who have a certain percentage of. Help me out here, guys. You guys are the experts. Uninsured.
Mm-hmm. Yeah. Uninsured and Medicaid.
And I know MetroHealth always qualifies. St. Vincent's always qualifies. UH downtown qualifies in and out depending on the patients coming in to Rainbow. Rainbow always qualifies, right? And then for the extra funding, and then the UH Case Medical Center sometimes does and sometimes doesn't.
Interestingly, at Ahuja, we have seen an almost complete elimination of our bad debt and self-pay patients because of the Affordable Care Act. We've had such an expansion of Medicaid that many of the patients that we used to care for charity are now insured. So actually, that's a benefit to our hospital, which we sort of didn't expect.
Yeah.
And let me point out something that didn't happen with the Affordable Care Act in our experience. We had the advantage last year of having a Medicaid waiver. We put up the dollars that we get from the county, the public dollars, and they were matched by the federal government and allowed us to put 30,000 people into an insured product, very similar to Medicaid. So we took people who were uninsured and basically immediately insured them. People were in tears about this. Now, their prediction was that when you do that, the EDs are going to flood with people who are going to misuse the healthcare system, costs will skyrocket, and we'll be in big trouble. But here's what happened at Metro. We put these people into our structure, our patient-centered medical homes. We got them excellent preventive care. We got them excellent evaluation of any chronic diseases and treated those diseases. Our outpatient costs went up. Our outpatient visits went up. We had a population in that 30,000. 17 of them have been getting kind of intermittent care with Metro, so we already had a record on them. They were our patients, and then they became insured. When they were insured, those are the people that increased their outpatient visits. They interacted with the health system more effectively. Every single quality measure for their chronic diseases improved. Every single outcome measure improved. And the cost of these patients, we predicted it would be, the average cost was $580 per patient per month. It costs us $430 per patient per month to provide that care. Why? Because the ED visits dropped 60%. They didn't have to go to the ED because we were keeping them healthy. They had a doctor to go to. They knew they had a way to access the healthcare system. And they were healthier, so they had 19% fewer admissions. So the cost of care, I think, went down when we provided a good insurance. And it's, that's something that doesn't get talked about enough or isn't known well enough.
And just, is there another question? Let's go with that then.
Something I don't think that's been talked about too much nationally is that there is a state, Vermont, who will be implementing a single-payer system in the next few years. In your opinion, nationally, do you think this is something we should start to think about moving towards?
Dr. Longworth, since you lived in Massachusetts during the transition and then came back to Cleveland, why don't you tackle that question?
You know something, I will take that on. I am fascinated to see what will happen in Vermont. And I don't know what will happen. I think there are many advantages to a single-payer system. There are some disadvantages. I personally don't think that this country anytime soon will have the political will or appetite to move to a single-payer system. But I think we can learn a lot from Vermont.
You know, there are different models in the developed countries for healthcare, and they are not all single-payer models. And so I don't know that we have to move to a single-payer model to advance the quality and affordability of healthcare in the United States.
Good afternoon. So the social determinants of health and wellness seem to me to be interdependent as we move forward in this whole transformation. What strategies do you have that you can share with us for those of us that are public administrators and public health professionals that we can take back as we begin to think about this in effort to, of course, decrease emergency room rates, but improve overall patient care?
That's a good question. Dr.
So
Longworth?
perhaps I'll start. One of the $64,000 questions in this country today is how do we better engage and activate patients in their care? How do we transform the vast majority of consumers from passive, health illiterate individuals to people who are knowledgeable about their care, who understand the choices they make, why they're on medications, and make the right choices? Nobody has figured that out in this country yet.
Don't you think
We're on a
high-deductible
journey.
health plans are kind of forcing that, though?
Sorry?
Don't you think high-deductible health plans are forcing people to say, I don't want to pay that, I'm going to have to take care of myself?
So
It's making them good consumers.
it's making them good consumers, but
But
here's
those
my
are people
concern.
with insurance.
Here's my concern about those plans. I'm worried, and we've seen some of this at the clinic, is that the people who have silent diseases, where they don't feel the symptoms, or where they have a high deductible plan and they're thinking about showing up for routine things that might include prevention, they're not paying those dollars out of their pocket. And so I worry about the long-term effect of those plans moving forward.
So the takeaways for...
Well, the other big piece I think is access. You know, access to healthcare, especially in underserved communities. We've had for many years a traditional model where physicians provide primary care or health care to people in the communities. I think that's going to disappear. I think we're going to see a very diverse way of delivering primary care, primary access health care to people, nurses, nurse practitioners, lay people even. And so I think as a community person, developing a set of or a cadre of people who are educated or who have a high health literacy who can help provide health care in a church or in a school, I think that's something we're going to really need to do more and more of. And then they can interface with hospitals and health systems to create a network.
So with regard to tactics, we're thinking a lot about the tactics at the moment. And we view every touch of a patient with the healthcare system as a potential coaching, activation, and engagement opportunity. And that means beginning to teach caregivers, not just doctors, not just nurses, but caregivers at every point, new skills around motivational interviewing, about emotional intelligence and meeting the patient where they are and helping them to define real goals and identify real drivers that will incentivize them to do the right thing.
Thank you. I'd like to ask a question about our workforce, because you just hinted on it a second ago. Are we training too many doctors in the hospital and not enough on an ambulatory basis? And are we providing doctors with the right kind of contacts in terms of people who they will interact with, since most care is delivered on an ambulatory basis in the city on any given day than in the hospital?
I could start on that. I think the answer is we're starting to do that, but we're probably 10 years or 20 years behind in doing it. At Metro, for instance, we've shifted from 80 or 90% of the outpatient visits occurring on our campus 10 years ago to now it's 60% are out in the community and 40% are on the campus. But we haven't moved. Some of the training has moved out, but we really need to be training doctors where the patients are. And if we are going to prepare these doctors to function in the new way of providing care, they have to be learning it from their mentors in that setting. So I think you're absolutely right, Ron. We've got to get people out into the community and change the way we train people to take care of patients.
I would also say that at the level of the medical school, where you begin to get your fundamental training, that there are, moves about, change about here, especially here in Cleveland. There's the CSU Neomed Urban Health Partnership, which is very specifically training individuals for delivering health care in an urban environment with urban problems, and that's not at the hospital necessarily. So the curriculum is starting to be developed for medical students, which is a little bit earlier than the residency training, to begin to meet those needs, because it clearly is a need to train the next generation of physicians to be able to work well in the community and to have the communication skills and the sensitivity. I teach a class called Reflective Medicine, which some people would say is kind of touchy-feely, but it helps the students at the first year level and second year level get in touch with their emotions around having to treat people with chronic ailments, having to deal with situations of confrontational individuals or family members. And so these kinds of things that we're going to see more and more of in the graduate medical education arena.
So I'd like to just add to that point and build on what you've asked, Ron. I think it's not just about where we train them and the percentage of time that they spend in the ambulatory setting or in the hospital setting. I think it's about teaching a fundamentally new set of skills that have not been part of medical education. And what are those? They're listening skills. They're beginning to teach empathy. How can you teach empathy? Well, there's more and more data showing that patients of empathic doctors have better hard quality outcomes, better blood pressure control, better diabetes control, better lipid control. And so we're thinking about how to teach those sorts of skills. Self-reflection, emotional intelligence, team. More and more medicine is going to be a team sport. So I think we've got to rethink the way we educate caregivers and not just physicians for the new world.
Yeah, and that comes back to the value-based purchasing umbrella, really. I mean,
Yes.
the outcomes, if you're measuring outcomes, you find out that people do better when you have an empathetic doctor. So you start trying to teach to that.
You need to understand that your doctor cares about you. We used to say that people don't care how much you know until they know how much you care, and I think that's what you were talking about right there. That we need to be able to convey to people that we care about them, and people are more likely to take the advice of someone who clearly cares about them.
And understand this is a paradigm shift in physician education, because when we were educated, there was not attention placed on the relationship with the patient as a person necessarily. It was more about the disease and the treatment. And so we are beginning to train the new generation of physicians to think differently and to respond differently to patients.
And I think one of the challenges that we're seeing is that we weren't trained in any of those skills. And so while we are focusing on training the young people, we have to do a whole lot of faculty development to teach ourselves those skills and to engage partners from outside the healthcare profession to help us teach those skills as well.
I think we have another question before we run out of time.
Thank you. This has been a great discussion about the equation of value. I'm wondering, we heard at the beginning that healthcare costs here are 2.5 times the average elsewhere. Can you each tell me succinctly the two biggest drivers of that difference, and are those drivers informing the actions we're taking to improve quality?
That's interesting.
Well, I think that here in Cleveland we're affected, just like the rest of the country, with the two biggest things that are driving healthcare. We've got an aging population, and we have a disproportionate emphasis on end-of-life care and poorly managed chronic diseases. And I think those, in a nutshell, are what's really driving it for most of us as we're trying to get our hands at our individual systems around how to manage those two things. But I think that's the biggest driver, the aging population.
And again, I agree. It's critical care medicine. We do way too much of it here in this country. especially in people who are elderly, who are, it should be at the end of life, where palliative care and hospice care should be where we're driving our focus. And that's a big part of the Affordable Care Act too, and this is what became politicized as the death panels, because we really were going to start reimbursing physicians for having those end-of-life conversations that I think was dropped out of the Affordable Care Act, unfortunately, but we really invest a huge amount of money there, and then in all the technology that we've got, just the advanced technology that's paid at a very high rate because we've allowed that to happen, and that's where a lot of that cost is going to.
And I think we're putting resources sometimes into the wrong things. We're spending a lot on imaging technologies, diagnostic tests that are necessary for understanding disease, but we're often not choosing the least expensive or the most. A lot of resources go into over-testing, which in a way reassures people, but at a cost that doesn't really give them any additional health. And we haven't been putting money into things that do improve health, like preventive care and a good management of chronic disease at early stages so you don't develop long-term complications that are costly. Keeping people healthier is the best way to get the cost of the healthcare system down.
Dr. Longworth.
So I would agree with all of the comments that have been made, and I want to add one more politically sensitive one to quote an icon in American cartoons, Pogo. We have met the enemy and he is us. We have a big appetite in this country for health care. We like gizmos, gadgets, diagnostic testing. We go to the doctor all too often with ailments, and we want tests, medicines, and procedures. And so I think we have a serious discussion to be had in this country about appropriateness of care. We're having that in the healthcare industry, but we need to have that as a society as well.
Excellent note to end on.
Today at the City Club, we have been enjoying a Friday Forum panel discussion on healthcare delivery from volume to value, featuring Dr. Alfred Connors, Jr., Chief Medical Officer of the MetroHealth System, Dr. Giesele Robinson Greene, Chief Medical Officer of Sisters of Charity Health System, Dr. Alan Hirsh, Chief Medical Officer of University Hospitals Ahuja Medical Center, Dr. David Longworth, Chairman of the Medical Institute of Cleveland Clinic, and moderated by Sarah Jane Tribble of WCPN. Thank you, Dr. Anderson, Dr. Connors, Dr. Greene, Dr. Longworth, Ms. Tribble, and thank you, ladies and gentlemen. This forum is now adjourned.